Welcome back, everybody. If you think that neonates do not feel pain, please think again. Neonates do feel pain. Neonates do feel even minor procedures. When we do endotracheal tube suctioning, when we remove the plaster, even when we position the baby, this can cause a lot of pain to the neonate. Either term or preterm babies, they do feel pain. They do present their pain. But sometimes we as healthcare providers do not appreciate this pain. So we have to be able to address this pain, to assess it, to manage it properly, and to document it in the right way. Luckily, we do have lots of assessment tools nowadays, so it's not as difficult as it used before to assess this pain and manage it in the right way. Now, perception and localization of pain in neonates does not present. This is a myth. Another myth is that no pain memories in preterms. This is not true. Pain threshold is high for pain which protects neonates from pain during birth. This is a myth. So what are the facts about pain? In 1987, an article which was published in the New England Journal of Medicine talked a lot about the issue of pain in preterms, and some statements were clear enough to guide all healthcare providers that newborns, either term or preterm, do have or do feel pain. So in that article, they mentioned clearly that pain pathways are well developed in the fetus late in gestation. So not only the newborn, but also in the fetus. They said also that physiologic responses to painful stimuli have been well documented in neonates of various gestational ages. Other facts we have to know about pain in neonates that newborns, both term and preterm, experience pain and have the right to receive safe, efficient, and effective pain relief. Do you think it's common for a newborn to have pain in ICU? Actually, it is very painful. A Cochrane review showed that an infant admitted to neonatal ICU or to special care nursery, he undergoes an average of 14 painful procedures a day. How many of these procedures have been addressed in your unit? And how many times did you give the right treatment or prevention of pain? This is a great question. Now, newborns, they cannot verbalize their pain, and thus they depend on the others to recognize, assess, and manage their pain. So being unable to verbalize does not mean that they do not feel pain. The objectives of my lecture are to define pains and to classify the types of pain, to mention some common causes of pain in neonatal ICU, to discuss the pain scores and pain assessment tools. Actually, here we will not go in details because this is different from one institution to another, and every institution has its own pain assessment tool, but we will mention some of the most commonly used ones. Then we'll talk about management options, including pharmacological and non-pharmacological, and lastly we will talk about some painful procedures, how to be addressed in neonates. So pain simply can be defined as an unpleasant feeling that conveyed to the brain by sensory neurons, while sedation, which should not be separated from pain management, is the reduction of irritability or agitation, usually by administration of sedative drugs. So what are the types of pain? This is very important because when you choose the assessment tool, you have to know this assessment fits this type of pain or not. We have actually two types of pain: acute procedural pain, which is the result of a specific painful procedure or event. It is usually self-limited. And chronic or persistent pain, which is a state that persists after tissue healing, usually beyond 3 months. Well, this slide is very important because it contains most of the painful procedures that we might think that they are daily practice. Actually, they are painful to the newborn, and before carrying any of these procedures, you have to think of giving a sort of pain management. So adhesive tape or suture removal is painful. Bladder catheterization is painful. Central line insertion or removal is painful. Chest tube insertion and removal are both painful. Chest physiotherapy alone or postural drainage are painful. Dressing change is painful. Gavage tube insertion, painful. Intramuscular injection is really painful. Mechanical ventilation, what do you think? It is painful. Peripheral venous catheterization is painful. PICC line insertion is painful. Tracheal intubation or extubation are painful procedures. Arterial puncture is or can be sometimes very painful. Eye examination, yes, it is painful, definitely. Heel lancing, it is more painful than even venipuncture. Lumbar puncture is painful. Suprapubic bladder tap or bladder catheterization, of course, it's painful, and any surgical procedure like peritoneal drainage or cut down are also painful. So, in assessment of pain, as we said, you have to make sure that you are using the right assessment tool. As we said before, we have two types of pain, either acute pain or chronic pain. So for acute pain, we have lots of assessment tools. I presented some of them here, like the PEP, NIPS, DAN, CRISE, INPAS, or PAT. And each one stands for what's mentioned here. For example, the NIPS, which is one of the most commonly used in states for neonatal infant pain scale. Which one you are using in your institution? Usually this depends on the policy that you do have. For chronic pain, we have, for example, the NPAS, which is neonatal pain, agitation, and sedation score, and the Eden score. We will start now talking about the non-pharmacological approaches to pain management, which includes many of the interventions, of which we will talk about in brief about 6 common non-pharmacological approaches, which include, of course, breastfeeding, skin-to-skin care or kangaroo care, music, non-nutritive sucking, swaddling or facilitated tucking, and multisensory stimulation. We'll come to the first and most important one. Breastfeeding is one of the most important non-pharmacological approaches. Here I will not talk in details, but I need you to know that breastfeeding as a pain management tool can be used during heel lancing, can be used during intramuscular injections, and can be used during venipuncture. But in order to be effective, this breastfeeding that the infant must achieve an effective latch, and there should be sustained sucking and swallowing for at least 5 minutes prior to the procedure. The second common practice of non-pharmacological pain management is skin-to-skin care or the kangaroo care. This is also one of the modalities used as non-pharmacological pain management. So skin-to-skin care should be maintained for about 10 to 15 minutes prior to the painful procedure to assure that parents and infant are fully relaxed and settled. Now, a lot of talk has been about the use of music as a pain management. Actually, it was proved until now that it is insufficient. There's insufficient evidence of using music. It may be used to support developmental care, but not as pain management. And here we should remember, if you are going to use music, remember that it should be carefully chosen and its use time is limited, about 15 minutes per intervention. Why? To prevent the risk of sensory overload. A fourth possible category of pain management is non-nutritive sucking. This is very important. It was found to reduce the acute procedural pain compared to no treatment. And if you use it in combination, especially with sucrose, it is more effective in reducing procedural pain than when used alone. The fifth procedure is swaddling or facilitated tucking. This one was found to be effective especially in preterm babies, but in a Cochrane review for term babies, it was there showed that there is no evidence of use of swaddling and facilitated tucking. Now, what's the point or the idea behind multisensory stimulation? Now, you need to distract the baby from feeling pain by giving him further or different stimuli. So you are giving different stimuli which will distract the baby from feeling the painful stimuli. How can we do this? By eye contact, by massaging the face and back, by speaking to the infant, by giving oral sucrose, by the smell of the parental natural scent. So all these surrounding stimuli will cause distraction to the newborn baby, so he will not feel the pain stimuli as if it was the only stimulus to the baby. Other non-pharmacological approaches have been discussed in details in the literature, which include simulated mother's voice, swallowing water, rocking or holding, toy distraction. All these procedures have been studied, but according to a recent Cochrane review, none of these were found to be effective as pain management. We'll go now to talk about oral sucrose 24%, and here I would like to take the statements or the conclusions of a Cochrane database review which was updated in 2016. Here it says that sucrose is effective for reducing procedural pain from single events such as heel lance, venipuncture, and intramuscular injections in both preterm and term babies. What about side effects? No serious side effects were found from the use of sucrose, but they emphasize the fact that no optimal dose was found for sucrose, and the studies were divergent in the use of doses in the management of the pain. It was found also when sucrose is used in combination with other non-pharmacological interventions, it was found to be more effective than when it's used alone. If you decide to use sucrose, you have to remember that it should not be used if the baby is known to have fructose or sucrose intolerance, if there is confirmed necrotizing enterocolitis, if the baby is unconscious or heavily sedated, or these babies who do not have gag reflex or unable to respond to handling, it's contraindicated to use sucrose. In cephalopathic babies or significantly depressed at birth until, of course, they are neurologically recovered. And if the baby is pharmaceutically paralyzed. In some cases, we can use sucrose, but with caution, like in babies who are already intubated, in babies less than 27 weeks corrected gestational age, and in infants with cardiac instability. How to administer sucrose by syringe, which should be placed on the anterior tip of the tongue. You can use it, as we said, with non-nutritive sucking, so the effect will be more pronounced, and it should be provided about 1 to 2 minutes prior to painful event. The mechanism of sucrose is still unknown. Now we'll talk in details about the pharmacological sedative interventions that used in neonatal ICU. This includes non-steroidal anti-inflammatory drugs, acetaminophen, morphine, fentanyl, benzodiazepines, and topical anesthetics. Non-steroidal anti-inflammatory drugs, we know that it is used commonly in pediatric and adult ages as painkillers. Actually, they inhibit prostaglandin synthesis by inhibiting the action of cyclooxygenase enzymes. But as a side effect, we know that they have effects mainly in the renal system and perhaps in the mesenteric circulation also. Actually, to be used as sedative or painkillers in neonatal ICU, there was no evidence that they have analgesic efficacy in infants aged less than 3 months, thus limiting their use in neonates. Of course, we have not to forget that we are using ibuprofen, for example, for the management of patent ductus arteriosus, and this is totally different from using non-steroidal anti-inflammatory drugs for management of pain. Acetaminophen, here, acetaminophen talk is really related to the newborn as a particular age group. Why? Because immaturity of the newborn's cytochrome B450 system may actually decrease the potential toxicity by reducing the production of toxic metabolites. In simple words, acetaminophen is less toxic in newborn babies than in pediatrics and adults. But if we are going to use it, we have to remember that for oral use of acetaminophen, we need to use less frequent dosing, for example, 8 to 12 hours rather than 6 hours. This is both in term and preterm babies. Why? Because of slower clearance times. If we're going to use it as rectal, we need higher doses due to decreased absorption, but it has also longer half-life, so less frequent dosing. What about morphine? Morphine is commonly used in neonatal ICU. It's the gold standard for procedural pain management in neonates. It's metabolized in the liver and excreted in urine. But it has a potential for late respiratory depression. So we have to keep in mind that babies may develop respiratory depression even late in the course of use of morphine. Fentanyl is from the same, it's another opioid analgesic used in ICU. It is about 80 to 100 times more potent than morphine, which means that we need less volume, and here we can give it to babies with cardiac problem. And also it's known to cause less histamine release, so it can be used safely in hypotensive babies. Fentanyl is highly lipophilic, so it has a quick onset and relatively short duration of action. Bolus doses of fentanyl must be administered slowly over about minimum 5 minutes to avoid chest wall rigidity, which is a common side effect in the use of fentanyl. Benzodiazepines, actually I myself do not like to use benzodiazepines in ICU. It should be used with caution in neonatal ICU as sedatives, but they are not analgesics. So there is no analgesic effect. The baby will be sedated, but he still feels pain. That's why this is one of the causes that I do not like to use them in ICU. Another cause that when you give as continuous infusion, they escalate rapidly in the blood, and this will cause a need for prolonged weaning. And in addition to being associated with abnormal neurological movement, especially when it is given rapidly, they have side effects on the respiratory also and the cardiovascular system. Now we'll talk about topical anesthetics. Imla cream is the most commonly used. It reduces pain of circumcision, and it must be here applied about 60 to 90 minutes before the procedure. There is a slight risk from the use of Imla cream in babies who are known to have G6PD, because these babies may develop methemoglobinemia. And it's not recommended to use Imla cream for infants who are more than or equal to 30, except for infants who are more than 37 weeks gestation. We need to know that Imla cream has limited efficacy with venipuncture, with arterial puncture, and with percutaneous venous line placement. And it does not diminish pain from heel lancing. So don't think that applying Imla cream is enough for the pain of heel lancing. Here we will present some commonly used procedures in neonatal ICU and the suggested action as painkiller in these cases. We will follow them one by one. For example, for bladder catheterization or suprapubic tap, the options here to use non-nutritive sucking or holding and swaddling, or oral sucrose 24% about 1 to 2 minutes before and throughout the procedure. For chest tube insertion, we can use non-nutritive sucking. We can use oral sucrose plus minus subcutaneous lidocaine 0.5% and or buffered. And you can consider the use of fentanyl. If ventilated baby, you can use 1 to 2 microgram per kg. If not ventilated, 0.5 to 1 microgram per kg. Or you can use also ketamine. Endotracheal intubation, we usually perform this without any pre-intubation medication if the baby is in need for emergency intubation. But if it is an elective intubation, we prefer to use in a sequence fentanyl, followed by atropine, and then by succinylcholine. For heel lancing, we suggest breastfeeding or non-nutritive sucking if breastfeeding is not available, skin-to-skin care, which is ideal for heel lancing, or holding and swaddling. We can use also multisensory stimulation and oral sucrose. Again, you can see that here imlacrane is not applicable. For intramuscular injections, you can apply breastfeeding or non-nutritive sucking, whichever available, skin-to-skin care and holding and swaddling, multisensory stimulation, and oral sucrose plus minus IMLA, because it is said that it has some effect in intramuscular injection, but not that much effect. Lumbar puncture, yes, you can use non-nutritive sucking. You can use oral sucrose plus minus IMLA cream. You can use subcutaneous lidocaine, or you can use fentanyl, especially if the baby is ventilated, you can give him a dose of 1 to 2 microgram per kg. If not ventilated, 0.5 to 1 microgram per kg. Nasogastric and orogastric tube insertion. These are not without pain. So please consider giving babies a sort of pain relief. And it must not be a pharmacological one. Non-pharmacological managements are enough. For example, non-nutritive sucking, skin-to-skin care, multisensory stimulation, oral sucrose 24%. What about PICC line or peripheral inserted central catheter, peripheral arterial line, or venous cut down? Here you can use non-nutritive sucking, oral sucrose, swaddling, multisensory stimulation, or you can use fentanyl plus minus lidocaine. A last procedure in my lecture is the venipuncture or arterial puncture, or the IV insertion or removal. Here you can use breastfeeding, non-nutritive sucking, skin-to-skin care, multisensory stimulation, oral sucrose 24%, swaddling plus minus IMLA cream. Take-home message for my lecture today. Newborns, both term and preterm, experience pain and have the right to receive safe, efficient, and effective pain relief. Health professionals should identify, prevent, and manage this pain. These are my references. Thank you so much.